So my name is Jennifer Hicks. I am the Associate Director of our National Center for Stimulation and Rehab Research, and I'll be serving as the moderator for today's webinar. I'm pleased to be joined by two presenters today. AJ Seth is joining me here at Stanford, and Ricardo Matias is joining us from Portugal. They'll be presenting on modeling the scapulothoracic joint and how this model improves the accuracy of measured shoulder joint movements. So the goals of our OpenSim webinar series, before we dive into the talk, so OpenSim is a freely available software application for visualizing musculoskeletal structures and simulating the movements of humans and animals. So the first goal of our webinar series is to showcase the cutting-edge research that's being performed with the OpenSim software platform. OpenSim is also a geographically diverse community of users that's continually growing. So the second goal of our webinar series is to provide a forum for the OpenSim community to communicate and collaborate. A couple reminders about the format of today's webinar. We'd love to answer your questions, but we'll take those at the end of the presentation, and you can ask your questions using the text-based Q&A panel. If you need any additional technical help, you can consult the guide on our website. So now I'd like to go ahead and introduce our speakers. First, Ricardo Matias. Ricardo earned his PhD in human kinetics from the University of Lisbon. And now Ricardo is a guest researcher at the Neuroaction Research Group of the Scapulothoracic Model Foundation and a researcher at the Neuromechanics of Human Movement Research Group at the University of Lisbon. His research merges musculoskeletal modeling and advanced statistical pattern recognition techniques to help unveil the interactions of complex skeletal and muscle dynamics that are involved in producing healthy and pathological movements. Ricardo is also very enthusiastic about open science and has been a contributor to the OpenSim community, sharing his models and data. Then AJ Seth. AJ is the current architect of the OpenSim Modeling and Simulation API here at Stanford. He joined the OpenSim team first as a SimBios Distinguished Postdoctoral Fellow in 2007, and he's now a senior research engineer at Stanford. He received his PhD in biomedical engineering from the University of Texas at Austin, specializing in the control and simulation of human movement. AJ is passionate about developing and sharing models and computational tools that enable research and clinicians, like all of you, to better characterize and understand human performance. So with that, I will pass over the mic to AJ and Ricardo. Looking forward to your talk.
Thank you very much, Jen. I'm very excited to be here today. And a big hello to everyone, and thank you for taking time out of your day to join us in this webinar. I'm excited about sharing with you today some of our recent work in modeling the scapulothoracic joint and what that means for measuring and assessing shoulder movements, and especially for the movements of the scapula. Before I go on, I just want to say that all the slides should be numbered, and so you can refer to in your questions, you can refer to a particular slide number. That might be handy. Okay, so first off, what is scapula motion? So for those who might not be familiar, what's the scapula? So the scapula is this flat triangular bone on your back that rides on your rib cage, and it has some interesting features in that it has a connection to the thorax via the clavicle here, the skinny collarbone, and then it has the big glenohumeral joint. So, and that when you raise your arm up, so you raise this humerus bone up, and when you elevate it, come on, there you go, you can see that the scapula plays a major role in the range of motion that you get for the upper extremity. And as you would guess, if you have any disability that affects the motion of the movement of the scapula, it can be very debilitating, and especially for simple activities like lifting or reaching and feeding, and activities of grooming. So before I go into the details of the model, I wanted to just touch briefly on some of the broader goals from a kind of a clinical and a physical therapy point of view. And I'm going to steal the goal from a consensus statement from a past scapular summit in 2013, where they described that scapular assessment of patients with shoulder pain should include identification of patient shoulder dysfunction and abnormal scapular motion. To me, that means we need to measure the difference between normal and abnormal scapular motion and have a really good idea of what is normal to begin with. So we really need to measure shoulder kinematics accurately and reliably. So how hard could that be, right? And two, determine relationships between altered scapular motion and symptoms. And three, identify the underlying causative factors of the movement dysfunction. And these really speak to the need for models that relate motion to pain, since pain is the main symptom, and understanding what drives abnormal movement. You know, it turns out that it's not easy to measure scapular kinematics. Specifically, there are several challenges to achieving these goals. So what are some of these challenges? The first one are just the measurement errors. The scapula is moving below muscle and skin, and usually our sensors, our markers, are mounted on the skin. So we have all this scapular motion below the skin and muscle. So how do you actually capture the motion of a bone that's moving under tissue? Because of that inaccuracy, we're unable to really discern between individuals, and we can't distinguish between impaired and unimpaired. So it's hard to do the first goal in the patient assessment. And then also the standard description that I'll go into next is difficult to interpret and compare. So that's the description of the kinematics is difficult to compare. And it doesn't factor in the translation of the scapula, and doesn't locate the scapula in space. It's also difficult to test cause and effect relationships and what's causing movement and dysfunction. So I touched briefly on what I meant by the current standard for describing shoulder kinematics, and that's the ISD recommendations for scapular kinematics. And specifically, you know, we have a scapula reference frame here shown on these axes shown here in yellow, red, and green. Red being the x-axis, the y being the yellow axis, and z being the green axis. And these are defined by landmarks on the scapula. I won't go into great detail, but what we're describing is the three rotations about these axes to describe the motion of the scapula. And these, you know, are given names like protraction, retraction for the rotation about the y, medial rotation for positive rotation about x, and then posterior tilt. So as you can see, there's no measure of the scapula, direct measure of the scapula translation. In reality, the scapula is constrained to the surface of the thorax, and people have used constraints to model the ellipsoid surface, namely Van der Helm, and then also have used a regression fit to match the scapular humeral rhythm. So, in general, the constraints are expensive. And to simulate, they're computationally expensive and require stabilization methods. And if you prescribe or couple the motion of the humerus to the scapula or the scapula to the humerus, then and you develop those regressions based on normal activity, by definition, you can't capture or describe pathological motion. And so a lot of the fast performing models trade off scapular motion for speed. So either they use coupled motion or they ignore scapular motion to get high performance. So specifically, our objectives are to accurately capture and describe scapular kinematics in a way that's intuitive to discuss and compare, and it's easy to distinguish between different movements that an individual is performing. We also want to be able to improve the accuracy obtained from motion capture. I mean, the skin and soft tissue is a huge consideration, and can we use models to reduce that sensitivity to skin and measurement noise? And third, we want to be able to quantify the forces necessary to generate shoulder motion. This is getting to the cause and effect, what's causing the pathological motion. Newton's laws are causal relations, so we should satisfy Newton's laws, and we should be able to do inverse dynamics and compute reaction forces on the thoracic surface. And it should run quickly, so we should be able to do inverse kinematics and inverse dynamics at least in real time, so we have a possibility of doing these analyses in the clinic. For today, I'm not really going to talk about forces and try to hit home that the ability of the model to match kinematics and its robustness, and I'll discuss more about the tests we performed to do that. So first, let me just go over what we think are some of the more intuitive ways to describe scapular kinematics. So if we have this surface of the thorax modeled as an ellipsoid, and this idea isn't new. Van der Helm introduced this idea over 2 decades ago, 1994, I believe. So the scapula can ride on the ellipsoid, similar to how a ship is coordinates are moving on the surface of the ocean on the planet. We have our our longitude, and then elevation and depression are our latitude. Upward rotation is giving us our heading on the ellipsoid. And then we have internal rotation, which is bringing the medial border here, is lifting that border and this inferior angle off the surface of the ellipsoid. So can we design a joint type that has these coordinates as its fundamental description of the motion of the scapula? So the answer, of course, is yes, and we're going to do that by exploiting a mobilizer formulation that we developed to describe biomechanical joints. And this was described in detail in a previous publication in 2010. And we used as an example an ellipsoid joint described in internal coordinates that could enable the abduction, elevation, and upward rotation that we just described. And it really does match the ellipsoid constraint that Van der Helm proposed. And then we added another joint to enable the winging. So that's the final degree of freedom that lifts the medial border of the scapula off the surface. And we use the same ISD standards to define the reference frame on the bodies. And then we built this as an open joint so that we can get kinematics and perform inverse dynamics and forward dynamics and get reaction loads without constraints. So this is what an ellipsoid joint looks like. You can see that it goes up and side to side on the surface, and then it also spins on the surface that gives the heading or our upward rotation coordinate. And there are no constraints in modeling this joint. And without constraints, we have fewer equations, and so we can actually run quite a bit faster, in this case 10 times faster than if we modeled the surface with constraints. Now we have the ellipsoid and we introduce winging. In this case, we're doing the winging about the yellow axis here. This is our winging axis, the y-axis. Then we translate, spin, and then have this winging additional degree of freedom. So those are basically the 4 degrees of freedom we thought would be ideal in our our natural description of scapular kinematics. And again, there are no kinematic constraints to implement this. So how one of the main points is that we're not using the identical location of the ISD frame. As you can see, the ISD frame is at the acromion, and we've slid it over to be at the centroid of these anatomical markers between the acromion, the spine of the scapula, and then the inferior angle. So for how did we find the neutral position of this axis on this ellipsoid surface? So we align the root of the spine here to be level with T3 and T4, the inferior angle to be in line with T7 and T9. When abducted, in the zero abduction, so when we say neutral position, that means what does it mean when we're at zero of all of the coordinates? So we're at zero in abduction, we want the angle of the scapula with the frontal plane to be 40 degrees. Upward rotation to be roughly 10 degrees, upwardly rotated, and zero winging is when the medial border is actually against the thoracic surface, when all the other coordinates are in their neutral position. So points 1, 2, and 4 we derive from Mottram et al. And their dynamic stability of the scapula paper from 1997, and points 2 and 3 are from McQuaid et al., which was a perspective on scapular stabilization. Okay, so now we have a model. How did we actually validate its accuracy? We were very fortunate to get excellent data set from Paula Ludwig at the University of Minnesota, who provided bone thick sensor and landmark registration. Combined, we got about a 1.8 millimeter of accuracy with 3 tasks: arm flexion, abduction, and internal rotation, with the arm elevated at 90 degrees of elevation. And so what does that look like? So now we scaled our model to the subject's marker data. We have it in their starting position, and then we track their kinematics. So the pink markers are the ones that are fixed to the model, and the blue markers are the ones that are from the bone pin data set. So here we're looking at the flexion task. So the arm is elevating forward and up. And you can see that we're getting very good correspondence between the experimental markers and the model markers. The second task was abduction. So that's the arm raising directly to the side. And again, we're getting very good correspondence of the model markers with the experimental markers. Here's a different perspective. Should turn to the side again. Oh, just zooming in. And then finally, the internal rotation task. So that's the humerus is elevated 90 degrees. And then we're going to internally rotate the humerus to its maximal extent and see how the scapula moves. So there is a marker there. It's a bit hard to see. I should have made, and the other ones I made the scapula more opaque, so transparent, so it was easier to see. Okay. So we looked at, visually inspected the motion. Now we can actually look at some of the numbers. So what are we seeing here? So we see our peak RMS error differences in a few places. For inflection, we see that in the inferior angle marker, in abduction, we're seeing that in the glenohumeral joint center, and then internal rotation, we see that in the one of the thoracic markers, which is the top of the sternum, the notch in the sternum marker. And in all cases, if we average all of in all tasks, if we average all the marker errors, the RMS error, we're getting within the measurement error. So the measurement error, even with the bone pin data in the registration, where we estimated 1.8 millimeters. So even though we're just using a pretty crude fit with an ellipsoid to represent the thoracic surface, this would indicate that we can't do much better without doing some overfitting. So what does the kinematics actually look like? So we would expect from the motion here in the case of the flexion task to see significant abduction, which we do. You know, elevation is harder to detect. It's funny that it actually depresses a little bit. And then, of course, the major mode of motion is the upward rotation of the scapula, which we can clearly see in the figure and in the motion. And then a slight amount of opposition to winging. So the scapula starts off a little bit internally rotated and then is resisted as the arm is elevated to its maximal extent. So we're pretty confident that the model can accurately capture what we see in a healthy subject. The question is, and with bone pins, but how would it handle noise? So with actual skin movement and soft tissue movement. So we decided to add synthetic noise to test that, to test the ability of the model. So we added systematic and random offsets based on MRI measurements by Matsui et al. We generated 100 trials of synthetic marker data for each task. And then, so I should say 100 trials of synthetic marker data for each task and each noise level. So we did multiple noise levels. And then we compared the variability between using the standard approach of describing the model with Euler angles directly from the markers, and then using the model-based kinematics. So our noise model looks something like this. So if on the x-axis we have time, this is the task time, and here is the peak extent of the motion. So just say this is either the flexion or abduction task. This would be the peak elevation. So when the arm is maximally elevated, we define some maximum systematic offset that we're going to apply. And the maximum we obtained from the paper from Matsui et al. And they, for example, measured a peak offset of 40 millimeters. And they also measured the variability in their measurements. So, so we included the variability as basically an additional random noise component. So we have a systematic noise component and a random noise component. That gives us the magnitude or the offset of our that we want to add to the marker. And then we're going to add the noise as a 3D vector to our position of the marker. We do this by selecting a unit vector at random, well, in polar coordinates by computing the angles at random. So we randomly select theta and phi. That gives us a unit vector in space, and then we just multiply the offset. Now we have 3D vector, and we add that to the marker. So this is our noise that we add to the marker, and we hold the direction constant for every marker for over the complete trial. So yeah, so we get the direction randomly, and then we fix it for the complete trial. And then to test the whole space of possible distortions that you could get, we do 100 trials. So just to give you a flavor of what kind of distortions you could get, if all the markers on the scapula have the same angle, set in the same direction in which the noise is added, you can think of that as a shifting error. So all the markers are shifted uniformly. If they oppose one another, you can see that as shrinking or extending stretching the scapula. And then everything in between is some form of either a rotational offset or warping of the scapula. So we do 100 trials at each noise level to sample all the possibilities of error. So here's an example from the flexion task. So if we look at the variability here, this is a standard deviation of the Euler angles with noise, and that's the solution without noise. That's directly from the bone pin data. And then we look at the standard deviation of the model, tracking the noisy markers with the model. So this is doing IK, and we can see that we've significantly cut down on the amount of error. So so that was one noise level. So now we've repeated that over multiple noise levels, starting from 1 millimeter in that peak offset to 40 millimeters, which was the maximum that Mathieu et al. Had measured. And in red, so in red, the solid red line is the mean of the RMSE error. So that's the error between the noisy fit, the fit to the noisy data versus the clean data, so the direct bone pin data. So this is the difference between the two solutions. So you can see as we add noise, the difference between the two solutions increases. So this is, at some point we cannot rely on the solution from noisy data. And if we do use the model underneath, then we can push out the point at which we lose confidence in the measurement. And if we include our natural coordinates, or our joint coordinates of the scapulothoracic joint, we actually do even better. I mean, that's partly because we're parameterizing by 4 coordinates that are directly parameterizing only the plausible space of the scapular motion, whereas the Euler angles include all the cases, even where the scapula is violating the thoracic constraint. So if we choose a value to discern what is clinically distinguishable between patients, to say in this case 5 degrees, you can see that we are extending the noise that we could tolerate, upwards of 2 centimeters. So at this point, I'm hoping that we've convinced you that the model can play a significant role in reducing the effect of soft tissue, which was what we were hoping. And we've done this on synthetic noise. So the natural question is, well, how does the model do on non-bone pin data and non-synthetic noise? So real measurements and some activity of daily living. And so I'm going to switch gears here and call on my good friend Ricardo to take it away and give you a demo on how the model performs with skin-mounted markers And what does it look like for a kinematic, the kinematics of an activity of daily living, and what's the performance? So he's going to do this live in OpenSim.
Oh. Okay, so thank you, AJ. I'm really excited to be here and with the opportunity to share with you all some of our latest research results. And for the purpose of this demo, we will use three-dimensional kinematic data of the thorax, scapula, and humerus collected with an electromagnetic system with skin-mounted sensors from an unimpaired subject while executing a shoulder shrug. So after loading a scale model, we can use a previously defined setup file to run OpenSim inverse kinematic and reconstruct the motion. In this case, shoulder shrug. And as you can see, we'll equally weight all the markers. So we can run inverse kinematics. Okay. So as you can see, it took us around 3 seconds to reconstruct an activity of near 5 seconds. And this is how it looks, the reconstructed motion of the shrug activity. If we now load the experimental data, we can observe how accurate the accurate result is. So we just preview experimental data and load the shrug data. And once again, the pink markers are the model markers, and the blue ones are the markers that are the experimental markers. And if we sync both motions, we can easily, as you can see, we can easily observe that we have a very small reconstruction error. And if you consider how well the model markers, so the pink markers, corresponds to the blue experimental markers. So I think this really highlights how the model really reconstructs with high accuracy, in this case, skin-mounted sensor kinematics. So, okay. Now we'd like you all to do an exercise. So in this slide, we have the initial in green and the final position in orange of the scapula during the shoulder shrug we just observed. So the scapula local coordinate system, as AJ just described, was defined according to the ISD recommendations. So x-axis points forward, y-axis upward, and the z-axis medial-lateral to the right. And we would like you to please take 1 minute to analyze both figures and choose one of the following Euler angles that you believe best describes the scapula final position, so the orange position relative to the thorax. You should use the poll window that will appear on your screen to introduce your answer. Ending it. So hopefully everyone introduced the answer in the poll questionnaire, poll window. So I think we are processing data right now. And if you got it right, you select option A. So the relative orientation of the scapula with respect to the thorax, it's 30 degrees of protraction with 10 degrees of lateral rotation and 15 degrees of anterior tilt. So 67% reply with they have no idea, and option B was the most answered and coming to the A. Okay, so now let's take a look at the second exercise. And for this one, we would like you to do the exact same exercise, but now using the internal coordinates of the presented shoulder model with the abduction, elevation, upward rotation, and winging. So please use once again the poll window to introduce your answer in the next minute. So 15 seconds. So the poll is now ended. So while we wait for the statistics, hopefully you choose the option B. So the orange scapula is slightly abducted, elevated 15 degrees, upwardly rotated about 30 degrees, and with a -5 degrees of winging. So some of you, 37% have still no idea. So this is half of the previous exercise, and almost. So you have the second best option was in fact option B. So it's 37% with answering the correct option. So I think we believe that the poll result highlights how the model internal coordinates can be more intuitive, even with just 1 minute to look into these numbers and to the figures, and how effective it is to describe the relative position and orientation of the scapula with respect to the thorax. So if we were able to decrease or increase the correctness of the response just in 1 minute, so we believe this, with some learning curve, you can really benefit from the use of this model when describing patients and daily living activities. So now looking at Euler angles from the same activity on the left side of your screen, computed as recommended by the ISD for the entire shred trial, we can see that the subject mainly used scapulateral rotation and anterior tilts to execute this activity. And when analyzing the motion from our internal coordinates on the right side of your screen, we can immediately say that the subject started with his scapula slightly elevated, abducted, and upwardly rotated when compared to the scapula neutral position that should be given with a 0 value. During the shred trial, the subject mainly used scapula elevation, upward rotation, and some scapula abduction in the end. Sorry. As you can see from the Euler angles, it is almost impossible to have a sense of this subject's shoulder girdle position with respect to the thorax and the degree of scapular winging. Both of them are clinical relevant when assessing the contribution of the scapula for the upper extremity kinematics, both in the clinical setting or just for research purposes. So currently we are processing kinematics from daily living activities of both impaired and unimpaired individuals. We already add muscles to the model and added them to match experimental cadaveric data such as muscles moment arm. We already successfully ran scapulothoracic and glenohumeral dynamic analysis with data from both impaired and unimpaired individuals in a collaboration with Dimitri Vlana. So in summary, and somehow to close this shoulder model presentation, we have developed a biomechanical model that captures the scapulothoracic kinematics and dynamics. As shown by AJ with some of our results, our model produced the kinematics of the scapula from surface markers to within the accuracy of bone pin measurements. All kinematic and dynamic analyses were executed faster than real time. We saw that in the inverse kinematic results. And for more details about the formulation and dynamics of the model and the results for inverse dynamics and for simulation, please just download our paper published last January in PLOS ONE. You can download the model presented in this webinar from the SimTK project's model of the scapulothoracic joints. Also, if you want to gain some insights and hands-on on how to use the model, we'll give with Dimitri Vlana a half-a-day hands-on workshop using this model on the opening day of the International Shoulder Group Conference this next July. In this hands-on workshop, it is our goal that by the end of the workshop, all participants will be comfortable with the OpenSim interface, the market set used in this model, with importing experimental data, with scaling the model and running inverse kinematics, like we just did. We are grateful to Paul Ludwig for the extraordinary bone pin data and to all the institutions that support our research. So, Jen.
Yeah, thanks for a great talk, and love the demo and the poll made us all think in the morning. So we'll go ahead and get started with the Q&A session now. As I said at the beginning, we'll take the questions via text. So find the Q&A box in your WebEx controls and go ahead and type in your question. Make sure you select to ask all panelists. All right, and we actually already have one question that's come in, and this is a question from Maxime Bourgain. In a matter of experimentation setup, how do you measure the positions of the markers on the scapula? In particular, the marker on the bottom of the scapula, which could shift experimentally due to skin motion.
Well, AJ, I don't know if you want to respond. I can start. For this purpose and for the purpose of this webinar, all the data collected, both using the bone pin and also the skin mounting sensors, were collected with an electromagnetic system. So yes, sensors are mounted on the skin, but then the landmarks are digitized and their position relative to the sensor is recorded by the system. So you don't have like the traditional reflective markers on the root of the spine, on the acromion angle or the inferior angle of the scapula. So although you have some published papers about this issue, how to collect information from the scapula with skin mounted reflective markers for this purpose, and I would say 85 or 9% of the shoulder research that is related to the scapula uses an electromagnetic solution to do that.
I'd just add a little bit more detail in the sense that the electromagnetic sensor is on the acromion. So it's probably the most bony accessible part of the scapula that we have. And then the other points, like the inferior angle is digitized with respect to the reference frame on the acromion. So yeah, we don't actually put, I don't think anyone now puts actual markers on the skin over the inferior angle. It's a good question. Thank you very much.
Okay, the next question is from Stefan Van Dragelen. So he says, thanks for the nice presentation. This question is about scaling. So we noticed that the distance between IJ and C7 is only 9 centimeters in the model. this small distance causes my model to expand in depth way too much. So it sounds like you've actually tried to use the scale your model, which is great.
Yeah, I don't know if you want to introduce the optimization scaling procedure, or.
I mean, for the scaling of the thorax depth, that we didn't even use optimization. We based that on the marker data that we obtained from Paula Ludwig. So we assumed that so maybe the geometry looks scaled incorrectly. That's possible. But in terms of like the landmark locations, yes, in some cases you can't trust what the skeleton is looking like as much as the actual location. So we're using I think that's correct. Like I mean those are pretty much direct measurements. So why does it scale too large in your case? One difference could possibly be that if you're using surface markers, you know, you're taking into consideration a lot more tissue in between, whereas the anatomical markers that we were using were like actually within the bone. So that could be a big difference.
Yeah. Yeah, I think you really highlight a very important issue. That is, when looking at the model, we have this intuitive analysis, anatomic analysis. That's what we are seeing is the thorax, but it's a representation of the thorax, and we really should keep in mind that we are scaling this geometry based on the marker positions. There are then whose distance of the molecules markers are minimized. So I would just make sure that you are really using the same marker setup. So it's on IJ and C7, and that you are not using the centroids of those markers to scale the thorax. But we could help if you just email us with some examples, and we can try to help you on that.
Great. So the next question is from Brian Kirking. So the generalizations of scapular motion is that the SHR, scapulohumeral rhythm, changes with increasing arm elevation. So what type of SHR do you get from your model, and is it consistent with arm elevation, or does it change with arm elevation?
Well, at this time, we were really focused on the validation and verification of the model from both a kinematic and now from a dynamic perspective. We didn't yet quantify the scapulohumeral rhythm and compare it with some published results for both unimpaired and impaired individuals, and try to see what is the ratio and if you are matching what is published or not. But that could be explored
but I think we've performed a stronger test though. So the scapulohumeral rhythm is a way of implying or deducing what the scapula is doing when you can't really measure it. So we've measured the scapula directly. So I mean, it would be interesting to see what rhythm we get and see how it compares. I wouldn't say that if we got something different that it was wrong, though.
Yep.
All right. So now a question from Andreas Contaxis. Does the model constrain the medial scapular border to the ellipsoid? And if yes, how do you model winging?
So there isn't a constraint between the medial border and the scapula. So you can think of the scapula as being connected to the ellipsoid at the origin of the scapular reference frame, and we computed that as being the centroid of the three anatomical markers: the AI, the TS on the spine of the scapula, and then the inferior angle. So that point is riding on the surface. and then it wings based on the y-axis. So like, I don't know if I should bring up the figure or not. Yeah. So wings about the yellow axis. Yeah, go back to our model. What? Yeah. Okay. Keep on going. There you go. Yeah, so I think in reality, that the point of contact is moving, but in our simple, relatively simple model, we just fix the winging axis to be the the local reference frame, y-axis. So the the medial border can actually, yeah, it does lift off the surface.
But both can be modified. So these points, so the location of the coordinate of the scapula frame and both the direction of the winging axis can be modified in the scapulothoracic joint.
Yeah, but it's important to note that we didn't have reason to move it because we were already matching the experimental data to within pretty much the error of the measurement. So, yeah.
Okay, now a question from Shramana Ghosh. First, says thank you for the excellent talk. On slide 13, you talked about constrained and unconstrained joints. Mm-hmm. Could you explain that concept a little bit more?
Yeah, that's a great question, and I kind of just blew right over that. So there's different ways that you can model in a multi-body dynamics way. You can model joints. You can model them as, you can think of every body as having 6 degrees of freedom, and then you constrain away the degrees of freedom that you don't want. So if you have a ball joint, you would constrain away all the translational degrees of freedom. In OpenSim, we use an internal coordinate joint types and formulation where we only enable the motion. So there's only, for a pin joint, there's only 1 degree of freedom, so there are no constraints. And so in a ball joint, we have only 3 degrees of freedom, and our ellipsoid joint is kind of a generalization of that principle, and that we still have 3 degrees of freedom. There are no constraints. It's still an internal coordinate system, except that the coordinates are now coupled, so that when you rotate in the abduction and elevation, you're also translating on that surface. If you want more detail, I'd really recommend that you look at our nonlinear dynamics paper from 2010 that really goes into details of the formulation.
Great. So now a question from Malavika Nambiar. Is it possible to use this plugin with other models like the ARM26?
We haven't tried that yet, but that's our hope. Our hope is that other modelers out there who have done a great job in characterizing other aspects of the upper extremity that could take the scapula and plug it in, or even better, if we formed a shoulder group, an open shoulder group, to combine the best of all studies into one great model that everybody could use.
Okay, great. And it looks like we have one more question from Stefan, and that is about the mass of the model. So which segments are included, and how can I convert my subject's mass to a value which I can use as input?
So the mass of the model, so the thorax, scapula, clavicle, humerus, and ulna and radius. The kinematic model, I don't believe it has the segment mass as it is in the SynTK project, but it should be near to we also share the dynamic model, and that model will include, all the segments will include the mass and the inertial properties.
I mean, I think that we do use the mass and inertial properties from
on the kinematic?
Yeah, from Alsbar et al.
Oh yeah, it's come from Alsbar, yeah.
Yeah, from Kate's model.
So yeah, if there are no further questions, I'll just ask one clarifying question about this SimTK. So we'll follow up with an email that has a link to the paper and the project. So if you actually want to start using the model, do you have to use a special marker set? Do you have to make any special measurements? How do you actually start using the model to study shoulder movement in your subject population of interest?
Yeah, it's helpful to use the ISD Standard Marker Set. That's the one that we're pretty much adopting. So I think in that's most widely accepted. So I think in general applicability, that'll be pretty easy. I would really recommend running through the IK scripts and stuff that we provide that kind of walk through all the steps. And then it should be pretty straightforward to use our scaling routines to match your model to your marker data and then run IK.
All right, that sounds great. So thanks, AJ and Ricardo again, and thank you to everyone in the audience for all those great questions. I want to acknowledge funding support for OpenSim. OpenSim is funded by several grants from the NIH, along with the DARPA Warrior Web Project. Oops. Oh, you're controlling, Ricardo. I forgot. So you can learn more about OpenSim at opensim.stanford.edu. You'll also get a survey pop-up at the end of the webinar. Please fill us out to tell us how we could improve the webinar series or future topics that you're interested in. Oops, next slide.
Oh,
that was it. Okay. So thank you, everyone, again. Thanks, Ricardo and AJ, again, for the great talk. And we'll see everyone at our next webinar. Bye-bye.
Thank you.
Thank you.